Good morning and welcome to the UDS Reporting Requirements Training. My name is Brandy Johns and I'm the Training and Development Manager at Nevada Primary Care Association. Nevada Primary Care Association helps community health centers provide exceptional medical, dental, and behavioral health care to Nevadans by advocating policy changes, providing training and technical assistance, and creating economies of scale through program management. For more information, if I switch my slides here. For more information, you can visit us at nvpca.org. This presentation is in partnership between the Nevada Primary Care Association and JSI, and I want to take a minute to thank them for helping us coordinate the session. This training is part one of the UDS training, and we'll have part 2 on December 16th, so make sure you join us again on that day. You'll be using the same login information for both of the trainings. Before I get started, I'd like to go over some housekeeping items. Please type your name and organization into the chat box. It's nice to see who in the community is attending the presentation. Also, please, if you have more than one person in your room with you, let us know that in the chat box so that we can make sure we're tracking for everybody that's attending today. During the presentation, please make sure to mute your phone. Please mute your phone or computer so we don't have feedback or background noise. Also, please don't put your phone on hold or you'll hear the hold music. You'll have the opportunity to submit your questions to the presenter by typing your questions into the chat box. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A sessions at the end of today's presentation. Today's presentation will be recorded and slides and all documents were provided in the Dropbox through email. Please let us know if you have trouble accessing those or you didn't receive them. And I will now hand it over to today's presenter, Megan Hiltner. Thank you, Megan.
Sure thing. Thanks, Brandy. Hey, good morning, everybody. Welcome to the training. I am grateful that you're willing to spend the next 3 hours with me. But heads up, I'll introduce myself in a sec, but I'm going to be doing a lot of talking today. So just want to set expectations that there's a lot here, but I'll try my best to use inflection given that we can't be face-to-face in a room, that we're in this virtual world. But so I'm Megan Hiltner, and I've been with JSI for about 20 years. JSI stands for Jon Snow, Inc. And I joke that it's not Jon Snow from the Game of Thrones, that it's Jon Snow, father of epidemiology. Though I've got to tell you, I've never seen Game of Thrones, but apparently Jon Snow's a good dude, and I'm grateful for that because that's good. That's good to know that it's not like I have to correct, like, oh, it's not, it's not this named after this evil person. But we're public health consulting, and we work internationally and domestically, and our mission is to improve the lives of individuals and communities around the world. So that's just a little bit about me. I have access to not just like the information that has been shared and all the resources for UDS reporting that the Bureau of Primary Healthcare puts out, but also a team of experts on this. So if questions come up, as Brandy mentioned, if questions come up for you, chat them in. I'll be sort of pausing incrementally to try and answer those. But if I can't answer them, I can tap into some of those experts at the break. We're going to take a 10-minute break in the middle of this today and see if I can get the questions answered then. If I can't, I will take them back. And so at the beginning of the next training, I'll have the answers for you. My goal is to really get you accurate information and make sure you know that through this UDS reporting process, you are not alone. There's a lot of help out there for you. And that, so you're feeling good about that. And Brandy is also, thank you, Brandy. She's been such a great partner in this. She's going to be chatting out some links to resources. You've been sent a lot of them already, but just at certain points when I'm talking about a specific section of the UDS, she'll be chatting out links to helpful resources you can go to if you do have some questions on that. So let's get started. Here's kind of our roadmap for the full training, the 2 days. First, we're going to review some overall key materials that are going to support you with the reporting. We're going to then take a high-level view of the UDS to really level set what it is, what do you need to know. After that, we're going to move into reviewing the individual tables and the forms that together make up the UDS. We'll start with the tables that make up the patient profile or those patient demographics. Then we're going to move into clinical services and quality of care indicators. These look at the type and volume of services, as well as process and outcome clinical measures. We're then going to move into the operational and financial tables, which describe the costs and revenues of your health center in the year. And then we're going to discuss the other required forms. There's 3 of these, and they're critically important. And then by the end, we're going to wrap up with some tips for success. So we've got a 3-hour block today that we're going to cover up through table 6A. That's the clinical services section. Then we'll pick up on where we left off then for table 6B through the tips for success on the 16th. And then there'll be an evaluation that's chatted out. You saw that this is being recorded, so you can refer back to that. And I joked with Brandy, I was like, well, if folks can't come to this one or the next one, they'll have the recording, but maybe they want to put me at 1.5 speed so they don't have to drag it out for the 3 hours. Maybe they can speed it up a little or something like that. So I might sound like a chipmunk, but the materials you received, I heard we saw in the chat a little earlier, some folks were able to receive, got that Dropbox of materials. But if you hadn't, Brandy had mentioned you can reach out to her. But the screenshot here reflects the Word document that describes the key resources that you got in that zip folder. And the Word document is really, again, it's a guide to the resources provided. And all these resources are available on the HRSA resources website. And they're really easily accessible. That's sites linked in the slide. But you got an agenda for today, so I know that it's just helpful to know what to expect. There's a list of acronyms. So for any folks out there that are new to this, that might be helpful for you. I do my best to spell them out as much as possible, but there is a list of acronyms. There's also a larger list of acronyms in Appendix I in the manual and a glossary as well. So that can also be a helpful reference point. Just do a handy Control F and you'll be able to find that, spell out some of those acronyms. There's an evaluation instruction and a link that's in that as well. There's a PDF of these slides that I'm talking about in the zip file as well. And for some folks that like to have like a printout with the notes page, that was included as well with the files. There's UDS reporting instructions, but that's also known as the manual, and I use that word a lot. That was included as well. These are the final reporting guidance for the 2021 UDS. The manual supersedes the training slides, and it really is the guidance that you're going to need to use, and it will be used by your reviewer and HRSA to determine accuracy of your reporting. There also included is the 2021 UDS tables, the actual tables. At some point in time, if you have a printout of these or you have a hard copy, at some points in time, I put in a slide, the table itself, and we talk it through. But if you have the hard copy and that helps you follow the conversation, you may want to bring that out. I'll call that out when we get there, but that was included. There's an FAQ for health center changes included. This is helpful for those who might have opened new sites or had other changes in the year. Then there's a number of references for each section of the UDS that I'll be calling out as well. You'll also find some selected statistics that might be useful to you as you compare your performance to your peers. The state and national roll-ups can be useful, and they're available on the HRSA website. The national roll-ups for each type of health center with 330 funding health centers, the lookalikes, and the Bureau of Primary Health Workforce awardees, they're there. These roll-ups show full data for the whole country. So it's just, I guess in the end, I know I've just rambled on about a bunch of resources. Just want you to know there's a lot of help out there for you. So let's get started with an overview of the UDS. So you get a big picture of what we're doing and why. So starting with the who reports the UDS? Well, health centers awarded 330 funding, including community health centers, migrant health centers, public housing, primary care health centers, lookalikes, also known as LALs, and the Bureau of Health Workforce awardees, the BHW, all which were designated before October of 2021 are the who. The what is reported in the UDS, that is a total of 11 tables and 3 forms that provide an annual snapshot of all in-scope activities. There is universal and grant reports, some if applicable, and the entire report, so all those tables and forms reflect the in-scope health center activities. Where is the UDS reported? Well, you'll report the UDS performance report in the electronic handbook, or the EHB. We'll look at that a little bit more detail in a couple of slides. When is the UDS reported? Well, reporting occurs between January 1st and February 15th of 2022. That is right around the corner. Reporting covers the calendar year from January 1st to December 31st of 2021. Again, we're going to look at that a little bit more in detail here in a sec as well. And why is the UDS reported? Well, for many reasons, including that it is legislatively mandated. It's also required by statute of the health center program. And it's used for program monitoring improvement. Through the UDS, it's possible to see the reach and the breadth of health center services and how those compare across the country. And so let's look at what that does look like. The reporting in the UDS allows HRSA to demonstrate what's shown here. In 2020, according to the 2020 UDS, health centers served nearly 29 million patients. The reporting in the UDS allows us to tell a story. The health center program served 1/3 of people living in poverty in the US, and 20% of people who are uninsured are served by health centers, as well as 20% of rural residents in the US. So a way of thinking about this is that the UDS is a point-in-time reflection of the services provided by your health center to your patients, how often your health center sees patients, and what it takes to provide quality services to them, the personnel, the costs, the revenues. And because all health centers must report this same data, those data can be used to compare yourself to peer health centers and identify areas of strengths and areas to prioritize for future improvements. We discussed a couple of slides back, the who, what, where, that whole thing. So the what of the UDS is 11 tables and 3 forms I mentioned. We'll review those here. We can consider the UDS in 4 primary sections, all of equal importance. First of these is the patient profile. It's comprised of demographic tables. There's the zip code table, table 3A, table 3B, and table 4. These 4 tables capture characteristics of the patient population served by health centers. The clinical services and outcomes, which includes table 5, table 6A, table 6B, and table 7, these 4 tables together capture the utilization and the services received by patients, as well as the process and outcome measures achieved through those services. So these tables really describe the nature and the outcomes of the care provided to patients. The financial and operational tables include table 8A, table 9B, and table 9E. These 3 tables together describe the costs and revenues generated by in-scope health center services. And the 4th section is the other forms, including the health IT form and the other data elements form and the workforce form. And I want to stress that these forms are as important and as relevant as all of the information reported. So please be sure to review the reporting guidance and ask questions that you might have about these forms when we get there. It's crucial that these 3 forms are completed accurately. And I know I've heard from some fellow trainers, we've talked about how we cover the forms at the very end. And by then, we're just running low on energy. And so I'm like, maybe we should move the forms to the beginning, but the flow does work nicely at the end. So at the end of day 2 training, I am going to be bringing as much energy as I can, because I do know that those forms are very important. So health centers with only one 330 funding stream, meaning only one health center program grant, or only one 330 grant of any type, will complete just a universal report. If the health center receives more than one Bureau of Primary Health Care 330 funding stream, meaning like CHC funding, as well as healthcare for the homeless funding, or migrant health center, or public housing primary care funding, they'll need to complete a universal report and a grant-specific report for each of the funding streams. Grant reports are a subset of the universal report. Grant-specific reports do not include the clinical performance measures or the financial tables. So as you can see in this slide, the grant reports include the patient demographic profile and table 5 and 6A. So no separate grant report is completed for the CHC grant, only a universal report. I mentioned the where in that who, what, where slide. So the where UDS reporting happens. The UDS is reported in the electronic handbook or the EHB. Here's a screenshot of what that is on the left side. There's several key notes. So everyone who will be working on the UDS needs their own login for the EHB. You want to check in on this sooner rather than later, including just to be sure that you have the needed permissions and access to the UDS performance report. Typically, the CEO needs to be the one to change permissions. So if by chance there's been turnover at multiple positions, this can take some effort. If you're in a situation or you have another account or a login related challenge, if you're having challenges, you can contact the HRSA call center. That 800 number is listed on the slide, and you'll hit option, well, it's an 877 number. You'll hit option 3 as indicated here, and they can help you out with that, any of those challenges with the EHB. There are a number of tools to assist with reporting as part of the UDS modernization process. So first, there's the preliminary reporting environment, which allows you to log into your UDS performance report before January 1st. And this is helpful for training. It's helpful also for downloading prior year data. Remember that remember that your data is not complete until January 31st. So you'll be collecting data up, you'll be reporting up through December 31st, that calendar year. But this preliminary reporting environment allows you to go in, and there are some things that you can do in advance. There is also an Excel template, which will allow you to complete your UDS report offline in an Excel file you can download, and then you can upload it to your EHB. There's also an HTML offline option, and these are helpful when you don't have to deal with any potential slowness in a system while you're entering any data. You can fill that in offline and then you can upload it. There's a comparison tool that's available, and it looks at your current year reporting and compares to the prior year. And there's an edits tool, which looks at potential data discrepancies. So I encourage you to access the strategies for successful submission webinar that one of my colleagues held on October 20th. It included a demo of these key EHB features, and you can listen to that and get some tips. Thanks, Brandy, for chatting that out. You can get some tips on how this can be used and what you could potentially do ahead of time. If during your reporting you have functional issues with the EHB, you can call the Health Center Program Support number as well. That's that same 877 number, but you'll hit option 1, and you can get support with that as well. So, being able to navigate the EHB is just really important. Okay, so here is some key timeline dates for you to write in your calendar. First, of course, through all of 2021, you're providing care and you're capturing the requisite data. And since October, the preliminary reporting environment was opened, and it allows you to log into the EHB and access your UDS performance report. But as of January 1st, the UDS report will open, as in the reporting environment will open for data entry, and then remains open through February the 15th of 2022. So February 15th, annual UDS, that's the annual UDS due date every year. Your UDS report must be submitted by the end of the day on February 15th, and there are no extensions. Once your report has been submitted on February 15th, it will be reviewed by your UDS reviewer. So between February 15th and March 31st, you'll work with your reviewer to correct and finalize your review, and be sure to adhere to the deadlines that you and your reviewer set together, or your reviewer, you can let your reviewer know that you need some additional time. Just communicate with your reviewer throughout that process. Then on March 31st, that's the final date for any potential changes. And any changes to the UDS must be complete and submitted and back to the reviewer. And thereafter, approximately April through August of each year, the data undergoes finalization by HRSA, And in August, the reports are made available in the EHB as well as on HRSA's data site for health centers and other stakeholders. So that's just a snapshot of some key dates. So I'd love to know a little bit about you all and sort of what you're coming in with your UDS reporting experience coming into this. That way I can know if I can just lean heavily on those of you that have lots of experience, or if there's some first timers here, I welcome you all too. So if you don't mind responding to this poll, how much UDS experience do you have? Is this your first time? Do you have a few years of UDS experience, 3 or fewer years? Do you have a good amount of UDS experience, 4 to 8 years, or are you an experienced UDS pro, 8 years or more? All right, so let's see. Okay, we got, all right, 48% of folks here are first time, and 28% of you have a few years, and then a good amount of 12%, and then an experienced folks here. I'm glad you're here too. So if you see something that you can respond to, hey, feel free to chime in. But first timers, I want you to know that the information here is tailored to sort of giving you that level setting that with that understanding of what UDS is. And just so you all know, we're noticing this is a similar trend across the country with these trainings. We got a lot of first time folks, so this is good. All right. So this is important for folks to be reminded about with the UDS, that everything that we discuss is interrelated. The UDS is a calendar year report that reflects an interconnected set of information for the whole program, the whole year, and the whole set of patients. So let's walk through what that means in broad strokes. So first, a health center patient is a patient with accountable visit, and that's on table 5 in the calendar year within 2021. The demographic characteristics of all unduplicated health center patients are reported on the zip code table, table 3A, table 3B, and table 4. Then the services and outcomes of those patients are reported on tables 5, 6A, 6B, and 7. Also, the personnel that takes to provide those services are reported on table 5. Then the costs incurred to provide these services to patients are reported on table 8A, while the revenues to cover those costs are reported on tables 9D and 9E. I'm not saying rambling these tables off for the first time, folks, that you have to know that. It's more of a big picture trying to sort of description of giving you a sense of how it sort of fits together. So to accurately report all this, you'll need to determine what health center sites or locations and services are in scope. It may be that all your sites and services are, or it may be that a larger organization that includes some of these other than a health center are included. Then you'll need to determine which patients had visits for in-scope services that were real-time and documented in the patient record, with a provider exercising independent professional judgment at those in-scope sites and location. So that's the definition of a visit. We're going to get into that in a sec, but so you're going to report on all those in-scope patients, those services, those FTEs, the costs and revenues in UDS. It's just it's interconnected, and all patients who are reported on the clinical tables anywhere are reported as patients on all the demographic tables. So for folks that by chance, for the seasoned folks, I guess, the health center changes and FAQs resources here. This can answer any questions for health centers that may have added new sites or services and had a change in scope or are newly designated. So if that describes your health center, be sure to check out this resource. All right, so in this section, we're going to look at health center patient population and by a number of characteristics. So the health center program is tasked with providing healthcare to underserved populations, and reporting in the patient profile gives us an idea of how successful we are in achieving this mission. Through the data on these tables, you're able to determine how many patients you serve, whether that number is in alignment with your projections and awards, where your patients live and whether that's in alignment with your service area, whether you are serving the patients who experience barriers to accessing care, such as those associated with characteristics such as race, ethnicity, language, sexual orientation, or gender identity, or people with limited income, or those who are or underinsured, or belong to a special population, such as those experiencing homelessness. Let's start by defining the term patient for the purposes of UDS. Each health center serves lots of people in lots of different ways, but not all those people will count as a patient on the UDS. To be counted as a health center patient on the UDS, a person must have had at least one countable visit in one or more service category on Table 5 during the calendar year. We're going to define a countable visit later in the training, but for now, just know that it's having a visit on Table 5. Each of the tables of the patient profile represents an unduplicated count of health center patients. Unduplicated means that each person counts once and only once, regardless of the number of visits that they had or the number of services that they received on these 4 tables. Throughout this training, then, when I say patient, I mean someone who had at least one countable visit for any type on Table 5, therefore is a health center patient in the 2021 UDS. The first table of the patient profile is the zip code table. It's also known as the patients by zip code and medical insurance table. You'll report the total patients by zip code of residence, or the patient zip code, and primary medical insurance. Primary medical insurance here on Table 4 is a characteristic of the patient. This is not necessarily the payer for the patient's visit in the year. So note that even if the patient was only seen for services that are not medical, like behavioral or dental, the patient's primary medical insurance still needs to be collected and reported. So for any zip codes with 11 or more patients, you can enter the zip code and the number of patients by insurance. You'll aggregate all of the patients from zip codes with 10 patients or fewer into the other zip codes category. And you'll use local addresses for migratory agricultural workers. And similarly, zip code for local accommodations for people from other countries. You'll use the clinical address for persons experiencing homelessness if they have no other address. If they're staying at a shelter or otherwise have an address, you'll use the zip code of that site. So note that there are 4 categories for primary medical insurance on this table. So on Table 4, there will be more and funnel into these 4. So for example, on this table, patients with Medicaid, CHIP, and other public insurance are reported together, whereas on Table 4, they're reported separately. The numbers between the 2 tables must be consistent in order to finalize your report. That's just a heads up. And just note that the EHB allows you to import the zip codes from your previous year report, and even better, if you use the offline Excel file to enter your data, you can download the Excel file with the prior year zip codes that are already entered. A frequently asked question we get often is, do we need to collect information and report on the primary medical insurance of all of our patients? And basically, yes. Although the zip code of a patient may be unknown, the medical insurance information must be obtained for every individual counted as a patient. So moving on Table 3A, patients are reported by age and sex assigned at birth. You'll report all health center patients by age and their sex at birth. So for states where sex on a birth certificate may be changed, you'll use the sex on the birth certificate, but it's not required to see the birth certificate. There is no unknown sex at birth, on sex assigned at birth on this table. So if there are patients that do not have an identified sex at birth, so for example, if a patient doesn't self-identify as a sex assigned at birth, or if birth certificate data are not available or definitive, patients must still be reported and assigned male or female at birth for this table, and clinical discretion should be used in these rare occasions. So note that this does not require that the health center change how the patient is identified anywhere other than on this particular table. Patients are reported by age as of January 30th of the calendar year measurement period. As with sex assigned at birth, there's no unknown age. So note that this is not aligned with the ages on some other measures of for example, the clinical, on other tables. For the clinical quality measures, there are specific birth date ranges that are provided. So again, this is an unduplicated count of patients, and total patients must match other total patient counts, like the zip code table we just talked about, patients by race, ethnicity, etc. They must match. Patients by age on this table must equal table 4, insurance by age groups. So the groups are 0 through 17 years and 18 and older. A fun note of on this one is that the table forms the foundation for the calculations for table 6B, the quality of care measures. So we're gonna keep plugging along here. Table 3B, like the others we've reviewed so far, it includes the total unduplicated count of patients, and everything on this table is self-reported by the patient or their caregiver and captured in the EHR. Race and ethnicity are separately reported, meaning each person has both a race, Asian, American Indian, Black, white, and an ethnicity, Hispanic or Latino, Latina, Latinx, or non-Hispanic, Latino, Latinx. These are assigned with the OMB standards for the classification of federal data on race and race ethnicity, cited from 1997, which spell out those OMB minimum category for race and ethnicity. So this is a structure set forth by OMB. Just wanted you to have that context. If race is known, but ethnicity is not, report in column B, meaning patients who have identified a race and not an ethnicity, you'll default to non-Hispanic or Latino, Latina, Latinx. If a patient reports Hispanic, Latino ethnicity, but no race, you'll report on line 7, column A, unknown race, Hispanic or Latino, Latina ethnicity. Patient should be able to select multiple race categories when they self-report. And those patients who select multiple races are reported in the quote unquote more than one race line. And remember that identifying as, for example, Black and Hispanic Latino is not more than one race, but rather it's race and ethnicity. Only patients with unknown race and unknown ethnicity are reported in line 7, column C. And some health centers may identify patients by more granular race ethnicity categories, and those should be rolled up into the categories listed on the table. So for example, some health centers may have an option such as Asian Indian, Chinese, Filipino, Japanese, Korean, etc. So, but for UDS, those would all be reported in line 1, Asian here. Report patients best served in a language other than English. So for example, Spanish, French, Arabic, American Sign Language on line 12. And line 12 is the only cell in the UDS that may be estimated. I hope you're sticking with me here. So all patients are reported by self-reported sexual orientation and self-reported gender identity in this section on table 3B. This is another area where you may collect information in a more granular detail than the categories listed here, but reporting must align with these specifications. For sexual orientation reporting, patients may identify as gay or lesbian, heterosexual or straight, or bisexual. These categories are fairly clear. The category something else on row 16 includes patients who identify as asexual, pansexual, for example. The category don't know on line 17 means that the patient doesn't know. Choose not to disclose means the patient chose not to disclose. meaning they selected, chose not to disclose, or prefer not to respond on their intake form. So lines 13 through 18 are all sexual orientation that the patient chooses. The last line, line 18A, unknown, means that there was no response from the patient recorded in the health center records, whether because it was uncollected or the patient wasn't queried or the response was not recorded. Gender identity reporting includes male, meaning cis male, or the gender response to birth sex, or female, cis female, a gender response corresponds to birth sex. Trans man, trans woman. Note that your health center may gather this information in other ways that are more appropriate for the patient population. For example, some health centers may ask patients their gender identity and whether they are trans, and the response of the two together would identify patients as cis male or trans male, or cis female or trans female. Then, so other, line 24, includes patients who identify as gender nonconforming or non-binary or any other gender. Choose not to disclose means that the patient chose not to disclose, meaning they selected chose not to disclose or preferred not to respond in the form. So just as with sexual orientation, line 25A in the gender identity section, unknowns means that there was no response from the patient recorded in the health center records, because it was, yeah, we just went over that. So the UDS manual, you can check in this section, and it has more definitions that may be helpful for you to refer to if you're running into any sort of hiccups in this section. So let's move on to the next table, table 4. Table 4 is part of the patient profile. So total number of patients by income reported on this table must align with the total patients on 3A and total patients by zip code and insurance. So further, this table crosswalks with those other tables in other ways. Patients by primary medical insurance here matches the patients by zip code. And the patients by age on table 3A align with the age breakdown of the primary medical insurance section here. So remember, all these tables are describing the same group of patients. So in the first section of this table, you'll report patients by their income as a percent of poverty. You'll use income based on the federal poverty guidelines. You'll report the most recent income data or confirmed with 12 months prior to the most recent calendar year visit. So it's expected that income, along with other demographic data, are collected at least annually. If income was not collected within 12 months of the patient's most recent visit, meaning verified or updated according to the patient's most recent income, report that it's unknown. Income collection is required, and if there are high amounts of unknown income listed, this might be flagged by your reviewer. Income collection should be done consistently with your board's policy, and insurance or other markers such as homeless status should not be used as a proxy for income. Income should be household income, including wages, salary, unemployment benefits, etc. So as I mentioned on the zip code table, patients are to be reported by primary medical insurance as of their last visit. So even if the patient was seen for a non-medical visit like dental or mental health, or was never seen for a medical visit during the year, the health center must still collect and report each patient's primary medical insurance. There's no unknown option in this section. All patients must be reported by primary medical insurance, and the total patient count by insurance needs to equal the total must equal patients by zip code, age, race, ethnicity, and income. I see that question in the chat box. Does BIPIC understand that many patients don't want to share their household income? That's a good point. I can't answer that one, but I am gonna, at our break, I'm gonna share that question with our team and see if anybody who has a more close ear to BIPIC, if they've provided any extra insights into that. So I'm glad you Glad you put it out there. Move forward here. So on the zip code table, we talked about 4 insurance categories. So table 4 insurance is broken down into more detail. Table 4 insurance reporting needs to align with the insurance reported on the zip code table. So none or uninsured. That is a patient had no comprehensive medical insurance, meaning medical insurance that covers an array of services as opposed to a limited scope, like certain tests or screenings or certain services related to a singular incident at the last visit. Patients who are uninsured, meaning they don't have insurance of their own, for whom the health center may be reimbursed through grant or contract or indigent care fund, are reported in uninsured as uninsured. And note that reporting on this table doesn't mean that you received payment from the insurer or that no payment was even received in the case of patients who are uninsured. This is really just defining a characteristic of the patient, which is what their primary medical insurance is. Who you received payment or reimbursed for services rendered is captured in 9D, but that's not until the next training. We'll get into that. So 2 examples, I'll share a couple here. So a patient may have a high deductible insurance plan purchased from a commercial insurer. So they may be responsible for most of their own charges, but on this table, they're not uninsured because they do have medical insurance. So the patient would be reported here, according to their plan, that they have private, or line 11 in this case. And then on 9D, their charges and collections may be self-pay because of the high deductible. Another example, so a patient may come to the health center and not be insured, meaning they don't have their own comprehensive portable medical insurance, but their services may be covered by a workers' comp or a local program. And in this case, the patient is reported as uninsured here on line 7, and their charges and collections are reported by the payer for whom that reimbursement was received from on 9D, such as other public. Those are just a couple of examples for that insurance scenario. Okay. So on the same line of conversation, managed care. So HRSA is interested in understanding which payers are using managed care, a managed care model, to what extent, and the mechanism of reimbursement that they use. It's also helpful to understand what portion of health center patients are assigned through managed care. Managed care organizations often have different names like MCOs or health maintenance organizations, accountable care organizations, coordinated care organizations. They also may have multiple plans with different payers. For example, an MCO may have both Medicaid and private. So on lines 13A and 13B, each health center needs to report all medical or comprehensive managed care patients who are assigned to the health center. Patients are reported according to the number of months that they were assigned to the health center. So for example, if they were assigned for the whole year, it would be 12 member months. And those member months are reported by managed care type, either capitated managed care on line 13A or fee-for-service managed care on line 13B, and by payer, Medicaid on column A, Medicare, column B, etc. Your health center must get your attribution lists or your lists of assigned patients in order to report on this table accurately. These numbers can't be estimated, so your health center may receive or download a monthly enrollment list of patients in the managed care plan. Some health centers report that they are downloadable from an MCO's portal. Patients are in managed care if they are assigned to the health center and then the health center is responsible for their primary care. So you'll report in this section only medical managed care. Dental managed or behavioral health managed care is not reported here. So remember that this section, again, it's capturing characteristics of patients. So the number of member months that they're assigned to the health center through their managed care plan, it's relevant to those characteristics. Then table 9D that captures the actual reimbursement received and the nature of that reimbursement, but we're not going to get into that today. Just wanted to connect those dots. I know somebody in the registration had mentioned they wanted to hear more about how the tables were how they were connected. So you may have managed care on table 9D that's not reflected here, such as managed care that's specific to dental or behavioral health. So this is a helpful example for you to sort of like look at this in a slightly different way. You're welcome to refer to your UDS tables for table 4 or table 9D if you have it handy, if you want to do that, but just otherwise you can just sort of I'll try and describe it. So you'll report enrollment in managed care across all payers using member months. And a member month is one member being enrolled in managed care and assigned to your health center for 1 month. That one person enrolled and assigned to the health center for January 2021 through June 2021 is, for example, 6 member months. This is why you need to get the monthly enrollment or attribution lists. You'll need to know if someone was enrolled and assigned to your health center for a while, then not assigned or attributed to you. So as I mentioned, you'll report the patient's member months in one of 2 categories based on how reimbursement is paid to you, either capitated or fee-for-service basis. Line 13A is capitated, which means that for a flat payment per month, per member per month, a service from a negotiated list are provided to patients assigned through a capitated managed care plan. Line 13B is fee-for-service plans, and these plans are paid according to the fees established for primary care and other services rendered for the assigned patients. This section of Table 4 doesn't exist in isolation, so we expect that if you say you have a lot of Medicaid member months, it should tie to the number of patients that you report as having Medicaid in the primary medical insurance section of Table 4. So this comparison is done by taking the managed care member months report for any given payer and dividing it by 12 to estimate how many managed care members it represents. So if the health center is reporting a total of 240,000 Medicaid member months in column A of lines 13A and 13B, that might represent about 20,000 patients. So we look at the Medicaid and Medicaid CHIP on lines 8A and 8B of the primary medical insurance section of this table. If those 2 lines only amount to, say, 6,000 patients, then the managed care reporting would suggest that there are more than 14,000 managed care patients assigned to your health center that we're not seeing. So the reporting on this table will almost always tie to the revenues you report on table 90. So if you're reporting capitated member months, we'd expect to see capitated revenues on table 9D. The member months reported here can be used in conjunction with managed care revenue on table 9D to estimate capitation payments, for example, in the lower right-hand corner of this slide. If the health center has reported about 1.05 million in Medicaid capitation payments on 9D and 36,788 Medicaid capitated member months on this table, then we could come up with an estimate of about $28 per member month. And does that seem right? I just recommend that these types of kind of cross-table calculations are done before you submit your report. All right, so income, insurance, managed care reporting on table 4 are closely related to the patient services revenue on 9D. So I'm not saying they're exactly the same, but just note that the table 4 characteristics of patients, table 4 characteristics of patients and table 9D describes the revenues from those patients. We'll get to 9D later. Yeah, we'll save that excitement for later. All right, so special populations. So all health centers must report these lines to the extent that they apply, meaning if a health center has patients who are agricultural workers, if they have patients who meet the definition of homeless, and if they have a school-based health center, then values will be entered in these lines. The health center program mission includes serving people who are part of these special populations. So it's important that this information be collected and reported. Just note that all the reporting in this section is limited to the health center patients. So the total unduplicated patient count reported throughout the patient demographic tables is there, and how many fit into these populations. On line 16, number of patients who are agricultural workers. This includes seasonal or migrant farm workers and their dependents, such as their children, who were seen at the health center for a countable visit in the year. This also includes aged or disabled former migratory agricultural workers who were seen in the year for a countable visit. Line 23, individuals who experience homelessness at any time when receiving services during the year. This can include children and youth at risk of homelessness or homeless veterans and veterans at risk of homelessness. Health centers may use the criteria as defined by HUD to assist in defining children, youth, and veterans at risk of homelessness. This is detailed in page 42 of the manual in the footnote. Line 24 are patients who receive primary care services at school-based health center. This is for patients to be reported in this line if your health center has a school-based site in scope. If you do not have a school-based site in scope, then no patients would be reported here. Do not include as patients, students who only receive screening services or mass treatment, such as vaccinations or fluoride treatments at school. We'll get into that countable visit in a moment here. Line 25, veteran patients, meaning patients who have been discharged from the uniformed services of the United States. The Bureau of Primary Health Care is working closely with the VHA to better support veterans, and collecting this and identifying veterans is really important. So note that this does not include veterans from military from other countries, and it doesn't include active duty service members. Line 26, total patients served at health center located in or immediately accessible to a public housing site, regardless of whether the patient is a resident of public housing. This is a site-based line. It doesn't require collecting any information from patients. This line requires assessing for each health center site if the site is in or immediately accessible to public housing, meaning city, county, or state managed public housing, not Section 8. If so, then all patients seen at each site that does meet the definition of a countable visit should be counted. Patients can be included in multiple lines on this section. For example, a patient may unfortunately be a veteran and experiencing homelessness. So a couple of reminders on this one. All health centers report special population lines, and these lines shouldn't be blank. So special population detail is only reported by those with special population grants. So the reporting for the public housing line in line 26 is location based. It doesn't come from the patient, but rather it's the number of patients seen at the health center site or in or immediately accessible to public housing. So just a little reminder there. So health centers that receive special population grants, like I was just mentioning, migrant healthcare or healthcare for the homeless, need to report the detail on their patients. And these are grayed out in the EHB for everyone else. So the EHB can kind of help with reporting in that based on what your site receives. Health centers who have migrant health center grant must report the nature of those migrant and seasonal agricultural workers. Patients are either reported as migratory on line 14, meaning they move around and establish a temporary home for the work. For example, someone who works on fishing boats in the Gulf for a few months of the year and then moves elsewhere to work in sugarcane fields for another part of the year, and then moves elsewhere to work in pork harvesting for the remainder of the year. That would be an example of that, a patient in line 14. Line 15, seasonal, means that the patient only has seasonal work. So think of someone who lives in New York and has agricultural work in an apple orchard or blueberry fields for 4 months of the year. If you're looking for more detail on this one and how to report patients who meet these definitions of agriculture as farming in all of its branches, these classifications are defined by the Office of Management and Budget, or OMB, and they're developed by the North American Industry Classification System, NAICS, and it's included in codes 111 and 112 and all subcodes therein, including subcodes 1151, 1151 and 1152. You can refer to page 41 in the UDS manual for a link to this detail if you are wanting more clarification there. That was a mouthful. So health centers who have healthcare for the homeless grant, they need to report healthcare for the homeless patients by their living situation or the nature of their housing status as of the first visit in the calendar year. This breakdown is on line 17 through 22. There's homeless shelter, transitional, doubling up, also known as couch surfing. There's street or living outdoors. Permanent supportive housing is there as well, other and unknown. More details on each of these is on page 42 of the UDS manual. And report lines 17 through 22, where individuals who experience homelessness are housed as of the first visit during the calendar year. Just another reminder on that one. A couple of tips, do's and don'ts, in summary of kind of what we just covered in this first half. So do roll up or aggregate data into the UDS categories if you collect race and ethnicity or sexual orientation, gender identity data in more granular detail than on the UDS. Do report all patients by income on table 4. Remember that patient income can be self-report for this table, not for sliding fee on 9D, but if consistent with the health center's board approved policies and procedures, it must be the patient income can be self-reported. It needs to be collected and updated and confirmed within 12 months of the most recent calendar year. And if the patient reports 0 income, then they are reported at or below 100%. And if unknown, you can report as unknown in line 5. Demographic information can be updated electronically through kiosk or intake form by phone. Demographic information is generally collected from patients initially as part of a patient registration or intake process, and then must be updated or confirmed annually thereafter. So those are the do's. Now on to a few don'ts. Don't include patients on the demographic tables. So that's the zip code, the 3A, 3B, and 4, who have not had a countable visit on table 5. Don't submit without double checking that all tables align. For example, age across table 3A and insurance on table 4, and primary medical insurance across the zip code table and then table 4. So in most cases, the system won't let you submit when these things don't align, but just wanted to call that out. And don't report patients with unknown medical insurance as uninsured in the zip code table and table 4. Be sure to collect medical insurance information for all patients. There's no unknown category for that medical insurance. So let's do this example. And after we do this example, I think we can let's take a 10-minute break. Let's review this example together. on a patient for table 4. And if you want to again pull out your tables, you can, if that's helpful. So Ramey was seen by the health center twice in 2021 in this scenario. For the first visit, Ramey had no reportable income because he was a seasonal agricultural worker and it wasn't yet apple picking season. When he was seen, he was couch surfing and staying with friends and family. And at this visit, he had no medical insurance. The second visit, Ramey reported that he was now making about $300 per week doing seasonal agricultural work. He was now staying in a worker's dormitory because he was experiencing homelessness previously. And at this visit, he had COVID-19, and his COVID-related care was covered by HRSA's COVID-19 uninsured program. Where would Ramey be reported in the income section? Feel free to chat your answer in if you want to do that, and we'll review this together. So I'm looking in the chat. Ramey's, oh, thank you. So he $300 per week times however many weeks each year Ramey works. Let's say this is for about half a year, it's about $7,500. This is below the 100% federal poverty guideline for an individual. So he would be included in line 1 of the income section, 100% or below. So that's where he'd be reported. Where do you think he'd be reported in the insurance section? So if you look back, he's uninsured for the whole year, even though the COVID-related care at his second visit may be reimbursed through the COVID uninsured program, but he would be included in line 7, column B, assuming he's over 18. And remember that in this section, we're describing the characteristics of the patient. So he's uninsured and that sort of thing. So where would he be reported in the special population section? He would be, he's an agricultural worker, so he'd be reported in line 16. If the health center were where he had his visit had a migrant health center grant, then he'd be also included in the seasonal detail line. That's line 15, because he's a seasonal worker. And also he was experiencing homelessness at his first visit and couch surfing, so he'd be considered doubling up. So he'd be included in line 23. And if the health center where he was seen had a healthcare for the homeless grant, he would also be reported on the doubling up detail line there on line 19 as well. So Brandy chatted out that fact sheet that could help with this one as well for table 4. But hopefully this just sort of connects you all to how this could play out in a scenario. So I know I've just covered quite a bit. I'm thinking this might be a good time to take a 10-minute break just to refresh. And it's right now 5 minutes past. So can everybody try to get back around 15 minutes? At 15 minutes past, and we'll start back up again. And I saw a question in the chat. I'll get back to that. I'll try and find an answer to that while we're taking a break. So. See you back in 10 minutes. Oh, well, welcome back, everybody. I hope you had a second to just step away for a second. I know this is like I said, a lot of me talking. All right, so now we're moving into the next section, which is services and quality of care indicators. Clinical service and quality data are reported across 4 different tables, tables 5, 6A, 6B, and 7. Today, we're going to get through tables 5 and 6A, and then we will get to 6B, 7, and the rest in the next training. So starting with table 5, it captures staffing and utilization. There are no major changes to reporting of table 5 for 2021 for you seasoned folks, that you can have that in your heads. And note that table 5 is the key table for determining if an individual is a health center patient. I've said this quite a few times before. A patient must have a countable visit on this table in order to be considered as a health center patient on the patient profile table. We looked at that earlier. So let's get into what does that mean, that countable visit. First, we're going to look at FTEs. So first on table 5, you'll report all full-time equivalents, FTEs, on column A. You'll report all personnel who provide support in scope of health center operations, including employees, interns, volunteers, residents, and contracted personnel by hours paid or worked. So where to report each FTE is based on, first, their licensure or credentials, and then second, based on their assigned duties or job description. So for example, you may have a pediatrician who's also the CMO, Chief Medical Officer. And that pediatrician is reported as a pediatrician on table 5. The time they spend overseeing the clinic and supervising other clinicians and clinical staff and running provider meetings, etc., is still clinical, so it shouldn't be separated out. But there is another example is if say there's a nurse who's also a case manager. If the nurse's duties and job title are case management, then the nurse would be reported on line 24, case manager, in the enabling section. It is possible to allocate a single person across multiple services, not to duplicate it, but rather allocate, say, like 60% of the FTE to one line and 40% to another if the person holds 2 different roles. But really, that should be limited for those personnel who hold and fill very distinct, 2 different distinct positions, and typically should not be done for clinicians. The time spent by providers performing tasks in which they could be considered non-direct service clinical activities like charting and reviewing labs and filling or renewing prescriptions or returning phone calls or arranging for referrals or participating in quality improvement activities, supervising all this, it's really considered as part of their overall medical care services and shouldn't be separated out or reported in a non-clinical support category. So 1 FTE is 1 person full-time for the entire year. So what is full-time? How is it defined by a health center? So one example, full-time is 40 hours a week. And maybe there's another example where 32 hours a week is full-time. It's really determined by your health center and defined by employment contracts for clinicians. Someone who is a full-time provider for the full year is reported at 1 FTE, regardless of the number of direct patient care hours they provide. Providers who have released time to compensate for on-call hours, like they have weekly administrative sessions when they do not see patients, or who receive paid leave for continuing ed or other reasons, they're still considered full-time per their employment contract. But because these activities, they're not direct patient services, it can vary. I don't want to get, I feel like sometimes that example might get confusing, but so if a provider is out on paid leave for some portion of the year, or if a provider spends half their time supervising, their FTE is still reported on the appropriate provider line, even though they may not be generating visits in that whole FTE. So those personnel who are not salaried could be more than 1 FTE. For example, if someone who's paid 50 hours a week for the full year, they could be more than 1 FTE, but this is a little less common. Don't include paid referral provider FTEs when paid services, when it's paid by the service, not by the hours. But you do want to count their visits and patients, but I'm going to get to the visits and the patients in a second. But so let's drill down a little bit on this FTE piece. So FTEs are reported by position, and as discussed on that last slide, service category, meaning medical personnel providing medical care to patients need to be reported in the medical section on table 5. Your behavioral health staff need to be reported in the mental health and substance use disorder sections and so on. So if you have a nurse practitioner who solely provides mental health and substance use disorder services or runs your behavioral health department, then they would be reported on line 20B, other licensed mental health provider, to reflect their licensure and the service area they work in, because that's solely what they do. Similarly, like with the nurse case manager example that I mentioned on the last slide, a nurse providing case management is reported as a case manager and can generate case management or enabling visits. Visits are always reported on the same line as FTE that are providing those visits. So as an example, you cannot report a nurse on line 11 in the medical section and then report their visits on line 24, case management. If the nurse did the visits, then they're on that same line. Similarly, like personnel cannot be reported on a non-provider line and then have their visits reported on a line that allows visits. Only some personnel can generate visits. There's an appendix of the manual, Appendix A, which starts on page 157, and it is a treasure trove of this information. It details various job titles and are reported and which personnel category is considered as a provider in the UDS and therefore can generate visits on this table. That Appendix A is really helpful to really dig into on this one. Here's an example of how you can calculate FTE if this is something new to you. So the first step is to determine the base hours for the calculation. So if full-time is 40 hours at your health center, then the base hours for that is 2,080 hours. For full-time staff with benefits, you'll take the paid hours and divide them by the base hours for full-time. So someone who worked at the health center for 6 months with full-time benefits would be 1,040 hours divided by the 2,080 hours, and that gives us 0.5 FTE. For personnel with no or reduced benefits, you'll remove the paid time off from the base hours. So let's say your health center has 10 holidays and 12 sick days and 5 CME days and 3 weeks vacation. That's a total of 336 hours of paid time off. You'll subtract that from that base calculation. So that 2,080, you'll subtract the 336 and you'd get 1,744. So that would be your base calculation for employees with no or reduced benefits. You would then take that paid time, the paid hours, that 1,040 in this case, and then you divide it by the base hours we just came up with, that 1,744. That would then give you that 0.6 FTE. The takeaway here is just not to deduct time off from full-time equivalents with paid time off. So it's important to understand that staffing and FTEs have costs, and these costs are reported on Table 8A. Alignment between reporting on Table 5 and Table 8A is very important and will be covered on the next training when we get to Table 8A. But in the spirit of connecting the tables and showing where they align with each other, I wanted to call that out. I've used this term countable visit on Table 5 a lot, and now let's really get into what that means. So in case I don't get into all your questions, or you just need a refresher when you start entering your UDS information and doing your report, you can go to this handout here that's on this site. That it's hyperlinked here, and it's on accountable visit guidance and frequently asked questions. It's really helpful. It provides some definitions and components. It gives you examples of what's not a countable visit. And so I encourage you to go there. So the UDS definition of a patient, remember, is a person who had a countable visit on Table 5. All your patient profile tables are limited to health center patients, meaning those people who had a countable visit on Table 5. So accountable visit, it is defined as a documented contact between a patient and a licensed or credentialed provider who exercises their independent professional judgment in the provision of services to the patient. The visit may occur either in person or virtually. However, these are just types or locations of the visit, regardless of the modality. The contact with that licensed or credentialed provider that provided independent professional judgment, it needs to be documented. And documentation generally must include the service codes, medical decision-making, level of risk and complexity for the services provided, the reason for the visit, and relevant history, including health risk factors, examination of findings, patient's progress, response to treatment, prior diagnostic test results that would be used to assess and treat the patient and provide a plan of care. The documentation could also include clinically appropriate examination or assessment, clinical impression or diagnosis. Note that a screening, like questions or checks to assess a condition, may confirm an assessment, but it is not an assessment. A screening alone is not a countable visit. And also that documentation may also include the total time spent on the date of the visit. The countable visit also is defined as a one-on-one. And I mentioned licensed credential provider exercising independent professional judgment, real time. So virtual visits are allowed for all service categories because visits need to be one-on-one. Group visits are generally not countable, but there are two exceptions to this. First, behavioral health visits, either mental health or substance use disorders. They can be group visits, therefore not required to be one-on-one, but all the other requirements remain. So they need to be documented in the patient record, must be real time with provider, so on. The term licensed credentialed provider in the case of enabling services or other services where there's no central credentialing body, meaning that the person hired by the health center to conduct those patient services within the scope of their duties could also be an exception to this. Remember that we discussed when we were reviewing the FTEs that not all personnel can generate a UDS countable visit. Appendix A, again, really details this out. Some key notes, though, on this. Clinical pharmacists, community health workers, patient navigators cannot generate visits. The UDS definition of accountable patient visit remains in effect for the 2021 UDS report. So the primary question that keeps coming up is that what about COVID testing and vaccinations? If an individual is screened, tested, and vaccinated for COVID-19, but the health center does not provide additional services that meet the criteria of a countable visit, so if that's the only contact they have with the health center, this person and visit are not reported in the UDS report anywhere. So typically testing and vaccination don't meet that documentation requirement that I went through a little bit ago, the service codes, medical decision-making, that whole thing. But I think that the note here too is that health centers provide so many important critical services that aren't countable in UDS, like mass vaccination, COVID vaccination, or testing, similar to like health fairs and outreach activities. They are very important, but they just are not reported in the UDS or not counted in the UDS. But a lot of times these activities and these important efforts can also lead back to the health center for visits that do generate countable visits. So sometimes a patient may be seeing more than one health center provider in a day. And I know somebody put this in the registration too, to kind of go through this. So I hope this gets at what you were hoping to hear more on. So as I have mentioned a little bit ago, if a patient has a visit On a given day, a patient may only have one visit per service category. So if multiple medical providers in a service category deliver multiple services at the same location on a single day, you'd only count one visit. So for example, if a patient has a visit and services are provided by an internist, an OBGYN, and like a general practitioner that same day in the same location, you'd only count one visit. A patient can, for example, have a dental and a medical visit at the same location on the same day. And provided that both of those visits meet accountable visit requirements, those can be counted as more than one visit. Accountable visit and accountable virtual visit and accountable clinic visit in the same service category in the same day would be considered two different locations. And so as such, that would be counted and counted as a different location. So two different, it would be considered two different locations, basically. As long as those both encounters meet the criteria for a visit and are with different providers. This image really tries to highlight contacts that don't alone count as visits. Obviously, these can be and are often part of the visit, but standalone, these don't count as visits alone. The chart details those as including health screenings or group visits other than behavioral health, tests and ancillary services like labs or imaging, dispensing or administering medications, health status checks, or other services like WIC outreach, fairs, health fairs, immunization drives, dental sealants. So largely these are excluded because they don't meet the criteria for independent or professional judgment. Frequently, these are services provide attendant to another visit. For example, a provider says, come back in 2 weeks to remove stitches, that sort of thing. Here's a little knowledge check, I guess, for you that let's go through each of these examples, and you can weigh in on if you think this is a countable visit or not. I'll read it, and then if you want, you can chat in if you think it is a visit or not a visit. Yes, a visit or not a visit. So the first example, Yvonne has not been seen at the health center before. She comes to the health center to get a COVID-19 vaccine. Yvonne signs in, filling out a brief form, and then a nurse administers the 1-dose COVID-19 vaccine. Yvonne leaves and is not seen at the health center again. Would you count that as a visit or not? I'm going to look at the chat box here. No, not accountable. You guys are on it. You know, yes. No, it's not a visit because it was just the COVID vaccine. Oh, yes, Renee. You're on it. So second, Charles is seen by his primary care provider at the health center for a regular checkup. In that visit, his primary care provider conducts a COVID-19 test and provides a flu vaccine. Yes, it's a visit. Yep. Okay, how about 3? A nurse at a health center calls a patient to complete several screenings, including a social needs screening, a PHQ-9, in advance of a scheduled appointment the patient has 3 days later. Yeah. You all are on it, not a visit. Yeah. As you pointed out, that the screening would not be a visit, but then the 3 days later, if that was the scenario afterwards, like she saw her provider, that would be a visit, but you all are right. Correct. Okie dokie. If you're using this slide deck as a reference for later or want to look back, put the answers in there for you. Okay, so moving along here. So one more important note for determining if a given contact is reported as a visit on Table 5 is that visits must take place in a health center site or another approved location that's part of the health center scope. To determine what an approved location is for your health center, you'll review your notice of award and or your Form 5B. Both of these are grant-specific information that are not part of the UDS, but define the scope of your health center's program award. You'll count and report visits provided by paid, contracted, and volunteer personnel in the health center, as well as those visits done by paid referral, no matter what the payment arrangement is, whether that's hourly or weekly or monthly or contract, fee for service. You'll also report visits when your health center provider follows current patients to nursing homes or hospitals or at home. So visits are not counted or reported if the patient is first encountered at these locations, that nursing home or hospital, unless that site is listed on your Form 5B as being part of your approved scope. Visits are broken out between two categories. Clinic visits, meaning in person, those are in column B, and virtual visits, meaning telehealth visits, which are column B2. A little more here, that clinic visits are reported in column B of Table 5 on the line of the personnel who conducted the visit. So remember, not all personnel can generate visits. So if the column is grayed out, as you can see in this slide on the screen, like with lab and x-ray personnel here, then no visits are reported. Clinic visits are the in-person visits that have traditionally been reported on the UDS and have historically been the predominant type of visits done by health centers. Though I guess those in-person ones, though 2020 has definitely had some upheaval to that. And so you'll report visits that meet the requirements of having documented face-to-face contact between a patient and a licensed or credentialed provider who exercises their independent professional judgment in the provision of services to that patient. Virtual visits. Virtual visits for all service categories are reported. The requirement for the reporting of virtual visits are just the same as the clinic visits, the same rules about which providers can generate visits and what that countable visit requirement is and so on. Those are the same. It's just a difference in the methodology of the visit. So you'll report virtual visits in column B2, and virtual visits are documented. So virtual or telemedicine contact between a provider or the licensed credentialed provider who exercises their independent professional judgment in the provision of services to that patient. They must be provided using interactive or synchronous audio and or video telecommunication systems that permit real-time communication between the provider and the patient. That store and forward method or asynchronous, not real-time contact, are not countable. Similarly, provider to provider contact, such as like an e-consult, those are not countable visits. Virtual visits need to be documented with telemedicine specific codes in order to be reported. So for example, GT via interactive audio and video telecommunication system, or 0.95 synchronous telemedicine services rendered via real-time interactive audio and video telecommunication system. There's a virtual guidance handout for reference if you want to check that out that you can refer to later. Okay, another knowledge check. We can go through these kind of each one at a time just to talk through each one, and on the next slide you'll have all the answers again if you want to refer to that later. So I will, how about I read the example and you can type in a yes or no if they are virtual visits or not. So health center provider provides in-scope services via telemedicine or telehealth to a patient not physically present at the same location as the provider. If you want to chat in, yes, is that a countable virtual visit or not? Yes. Kendall, you're right. Renee, you're right. Yes. All right, so next example, a health center provider provides out of scope services via telemedicine, telehealth to a patient not physically present at the same location as the provider. Is that a visit? Nope, not in scope. Jenny, you're on it. Yep. Nope. That's correct. All right, next one, a non-health center provider, not physically present at the health center, provides services to a patient at the health center through telemedicine, telehealth, and the health center covers the cost of the services by the provider. Is that a yes or a no? I see yes and then some yes and no's. And yes, it is because we cover the cost. That is right, because the health center covers the cost, which that's giving you a clue for the next one. Same example, but doesn't pay for the services. That would be a no, because the health center doesn't pay. All right, so we did 1, 2, 3, 4. We're at number 5. A provider at the health center confers with a provider at a different health center via video chat regarding a patient's care. Is that a yes? No, 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 no. You're right. That e-consult does not fit in the definition of a virtual visit. So the next one, a patient and a provider discuss a patient's health concern via a secure email through the EHR. Yes or no? I think I saw no. Yep, no, 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 no. You're correct. It's not real time. That's, yep. You are correct. That is not a visit. Okay, a couple more here. A staff member at the health center takes a photograph of a patient's skin condition and sends it through the portal to a provider not physically present. And I see some no's coming in. You're correct. It is not a visit. Last but not least, an interaction is not coded or charged as telemedicine or telehealth services. No. Yep, y'all are on it. So this one just gives you the answers if you're reviewing, coming back and reviewing some of these for a refresher. The answers are there. Thanks for participating. So let's bring what we've just covered all together. You'll report all countable visits in either column B, clinic visits, or column B2, virtual visits. Not all personnel generate visits. Not all contacts are visits. A single visit might contain multiple visits, but count as only one. Visits are counted on the line of the personnel who conduct the visit. Patients may have many visits across many services and personnel. You'll count and report the patients who receive these services by service category in column C. Remember that only those patients who had countable visits are reported here and anywhere else in the UDS. A patient may be counted in each category in which they had a visit. And table 5 is a duplicated count of patients, meaning that patients may be counted more than one time in the table in column C if they had visits in more than one service area. However, it's an unduplicated count of patients in each service category. So you'll report patients in each service category which they had a visit, but only count them once in each service category. And total patients on table 5 does not equal the total number of patients served by the health center because there's duplication across service categories. Okay, table 5. So we finished the main parts of table 5, but there's an additional section of the table called the Selected Service Detail Addendum. For all you seasoned folks, again, there's no changes to this part of table 5 for 2021. So you're old hats at this because you've done it before. But let's go through it for those folks that are new to this. So the Selected Service Detail Addendum captures integrated behavioral health provided by the health center. This means that the health center reports mental health services provided by the medical provider in medical visits. So those are the visits reported in lines 1 through 15 of that table 5. And something to remember is that this is limited to mental health services that are not already reported in the mental health section of table 5. So then on this addendum, the health center reports substance use disorder services provided by medical and or mental health providers in medical or mental health visits. Again, keep in mind that this is limited to substance use disorder services that are not already reported as substance use disorder visits on line 21 of table 5. And one key to note here is that column A1 of the addendum captures number of personnel, not FTEs. So it's an actual number. Again, not that FTE that we talked about earlier. It's a head count of providers who provided these services. And so I meant, as mentioned, column A1 is the number of personnel, that head count, who provided these services. On the selected service detail addendum, medical providers may be counted both in the mental health service detail section of the addendum and in the substance use disorder detail section of the addendum, if they provided both mental health and substance use disorder services in their medical visit. Mental health personnel may only be counted in the substance use disorder detail section, and only if they had mental health visits that included substance use disorder services. So we previewed on the last slide in the selected service detail addendum, you'll be reporting providers, visits, and patients where mental health or substance use disorder services were provided during a medical visit. Meaning if an internist on line 3 in the left side of the screen had a primary care visit where, as part of that primary care visit, they diagnosed the patient with tobacco use disorder, the provider, the visit, and the patient would also be reported in line 21A of the addendum as a physician visit that also included substance use disorder services. So here we can review another example. So in this example, a family physician has an in-person visit with a patient who has a diagnosis of depression and manages their medication for that depression during the medical visit. On the main part of table 5, that staffing and utilization section, the family physician's FTE is reported on line 1 of column A. The visit is reported on line 1, column B, and the patient is included in the medical patient count on line 15, column C. Then in the select service detail addendum, the mental health service detail, due to the integrated behavioral health services that were provided in the medical visit, the family physician is also counted as one personnel in line 20A01, column A1, and the visit is also counted in line 20A01, column B. So this visit is counted twice on table 5 as a whole, once in the main part of table 5 and once in the addendum. Mental health providers who were reported in the mental health section of the main part of table 5, shown on the left, may be reported in the substance use disorder detail portion of the addendum if they provided substance use disorder services in their mental health visits. So lines 21E through 21H on the addendum, what's on the right side of the screen, are the subset of mental health FTEs and visits in patients from the main part of table 5 that also included substance use disorder services. So for example, if you had a total of 20,000 mental health visits on line 20 of the left side of the screen, the visits on lines 21E through 21H would need to be less than that 20,000 because this is a subset of the total mental health visits. So remember, any FTEs or visits and or patients reported in line 21 of that main part of table 5 are not repeated in the addendum. These are substance use disorder services that have already been counted. All right, so here's another example. And this would be an example of an integrated substance use disorder. So a licensed clinical psychologist sees a patient via telehealth for depression complicated by an alcohol-related disorder. On the main part of table 5, the staffing and utilization, you'll report the depression treatment services visit and the clinical psychologist FTE on that 20A01. And the patient in the mental health total on line 20, the visit would also be in column B because it was virtual. Then this would also be reported in that select services detail addendum of table 5 in the substance use disorder service detail portion due to the integrated substance use disorder services provided by that mental health provider. You'll report the alcohol use disorder related treatment provided by the clinical psychologist in the personnel visit patient on that line 21F. And then the visit would be column B2 because it's virtual. So as I described above, this visit is counted twice in the whole of Table 5, once in the primary part of Table 5, and then once in the addendum. In no case can a visit be reported twice in that main part of Table 5, though. So in order to determine which visits are reported on the select service detail addendum on Table 5 for mental health detail, you'll use the mental health diagnosis on Table 6A, lines 20A through 20D, circled in yellow here. And when I say circled, I mean like the big circle, not just the yellow box. So remember, it's just those that were done by medical providers that would be in the addendum. For substance use disorder detail, you'll use the diagnosis on lines 18 through 19A of Table 6A, circled in red. Remember, it's just those that were done by medical mental health providers that are reported in the addendum. And again, it's the outer red. This slide also includes some will be a good reference point as you get to that part as well. All right, so let's look just a little bit more closely at that crosswalk quick for mental health. Table 6A, lines 20A through 20D in yellow on the left, corresponds with Table 5, lines 20A01 and 20A04 in yellow on the right again. Only those done as part of the medical visits are reported in the addendum. Many of these visits are already going to be reported in that mental health section, and we're not duplicating those in the addendum. They're a subset. For substance use disorder, Table 6A, lines 18 through 19A in red on the left, it corresponds with Table 5 addendum lines 21A and through 21H in the red on the right as well. So remember, some of these substance use disorder diagnoses will already be reported on the substance use disorder line 21 in the main part of the Table 5, and we're not duplicating those. So one check is that the total of these 3 lines on Table 6A is notably higher than the total on the substance use disorder line in Table 5, that's line 21. And then that likely means much of this is being provided by medical and mental health providers in those visits. Therefore, significant reporting would be expected on 21A through H of the addendum to capture the substance use disorder services in those medical and mental health visits by those medical and mental health providers. So here's some resources that you can dig into more of this. And I'm going to look at the question real quick and see if I can answer it. But these are all really helpful visits that you can go to for Table 5 reporting. So the question is, we have an APRN who sees behavioral patients only for medical management primarily. In the past, she was counted as a mental health professional, but she's an APRN. Where should she be reported? I think you should go back to if her job description and role description is primarily the mental health service or behavioral health provision, you would count her in that section. Here, we can go back to that slide and talk it through. Visits, countable visits. Here we are. Okay. So if she is, if she's seeing, if her duties and job title are more of that, any sort of enabling services, or it sounds like behavioral health services, they would fall in that line. But if her provision is more in her nurse, the provision of her the service category in that nursing line, then she would be there. I hope that helps. I don't know if others have reported staff in other ways, if other seasoned folks have have experienced the same.
This is Mary. Thank you for trying to answer the question.
Yeah.
The thing is, she is functioning for us as an APRN.
Okay.
And she primarily does prescribes medications
Mhm.
for the mentally ill population. She is a clinical nurse specialist who's certified as an APRN only for the behavioral health population. So the only medications she can prescribe are for mental health. But that's the primary role she's serving. She may do some occasional counseling, but she is functioning as an APRN with her clinical practice with her board licensure.
My guidance would be as the APRN and the nurse practitioner role. And then you would count her in the addendum as a one in that appropriate section. But I think I am also going to send this note back to the team to confirm that guidance is the correct guidance. But that's how, based on what you described, that's what the guidance I would have.
So she would be on 9A,
9A.
not 20C or 20B.
20 other licensed mental health providers.
In the past, they often counted her as an other licensed mental health provider. And my contention has been, but she's a nurse practitioner.
Yeah. But if her role and job duties are in a line in that with more mental health as a mental health provider.
Well, that's her specialty as an APRN.
Yeah. Yeah. I would say that the 20B, it sounds like, would be more in line with her role. But to your point, 9A, is more of her licensure. Let me send this. I'm going to send your question through my question channel for my team. And while we're talking, they will be able to respond.
Yeah, I think the important part is that primarily what she's doing is prescribing. She's prescribing.
Yeah.
And only psychiatrists can prescribe in the mental health realm.
Mm-hmm. Yeah.
None of the LCSWs or psychologists or anybody else can, unless they're in like New Mexico where psychologists can. But that's I just think that's an important point, is that she is a prescriber.
Yeah, I agree. Well, let me send that through and see if we can get an answer. We're a little bit ahead of time here, folks. So I think we'll have some more time if you do have Q&A that I can go back and forth with. If you have more questions, we'll have more time to get those answered.
Thank you so much.
Yeah, sure, Mary. That's a good question. Let's see. We are cruising along here. We've got the addendum. Here's all those great resources. All right, we're just going to get through this next section, and then we're going to be done for the day. Okay, so table 6A, selected diagnoses and services rendered. 6A is a selected list of diagnoses and services that are of special interest to the Bureau. Not every service offered by your health center is listed here. Column A reports all visits. You'll report all visits, clinic or virtual, in which the diagnosis or service was coded. And codes are provided to identify the diagnosis or service that's applicable. Services and diagnoses must have occurred in the context of a visit to be counted. So, for example, flu shots provided at a well visit or to a health center patient understanding orders, but flu shots provided at a flu shot clinic or a health fair to the public or not. A visit can be counted on multiple service diagnosis lines as appropriate. So an example of this is that a patient had an annual exam where a patient had asthma and received an HIV test and an STI test. That would count one visit on each line. Multiple services of the same type provided in the same visit are counted as one visit. So a visit with 2 immunizations provided is still one visit. Column B, report the total number of patients for whom you counted visits for that diagnosis or service. So patient counts are unduplicated within the diagnosis or service. Patients can be counted on as many lines as appropriate and duplicated across the lines. And remember, when we say patient, it means that it's that someone with a countable visit on table 5. And they were reported on that patient demographic profile table. So this is new. Last year, COVID vaccines were reported on the other data elements form, but for 2001, they're going to be reported here on table 6A, like other vaccines. Note that only health center patients who received COVID vaccines in 2021 are reported here. And each dose provided to the patient is reported separately. And the patient counts only once in this line. Be sure you're not counting vaccines given to people who are not health center patients. The first, second, and booster shots can all be counted when provided to health center patients. If each shot is done separately, as is typical in the case, which then each count individually on table 6A. Each alone isn't a countable visit on table 5, though. Because the COVID-19 landscape is ever changing and new codes can be released throughout the year for COVID-19 vaccines. If new codes are released and mapped directly as COVID vaccine, they can be used even if they're not listed in the manual. There's a PDF that is also a helpful resource on this one. And some keynotes for table 6A. Tests, procedures, screenings captured in table 6A, including COVID-19 testing, are only to be reported when they're performed by the health center or not performed by the health center, but paid for by the health center. Or if results are returned to the health center provider to evaluate and provide results to the patient, even if not performed or paid for by the health center. For example, a sample sent to the lab and the lab bills the patient, but then returns the results to the health center for follow-up with the patient. So remember, if someone is a health center patient, meaning they had a countable visit on table 5, and they received a service specified on this table, then that is counted on this table. Nothing else should be counted. Specifically, no patients who are not reported on that demographic table in table 5 can be included here, or can any services that they received. So here's an example. Let's say the health center orders a test and the test is done by LabCorp, and then LabCorp bills the patient directly. However, the results are sent back to the health center and the health center is tasked with the follow-up with that patient. Again, that counts. If you're wanting more guidance on selected tests and screenings, you can refer to the manual on page 71. There's some really good guidance on that section of table 6A. The one thing that the Bureau really wanted us to call out in these trainings for line 21 or PrEP. So a new line was added to table 6A last year, capturing visits and patients receiving PrEP or pre-exposure prophylaxis for the purposes of preventing HIV. Health centers must ensure that they report and count those prescribed PrEP based on risk for HIV exposure and limited to FTC, TDF, or FTC, TAF for PrEP. These codes are listed on table 6A, but are not sufficient for identifying this narrow set of visits and patients. And they're only a starting point. And from there, the counts would be reduced specific to PrEP medications administered as part of PrEP management. So CDC contacted the Bureau of Primary Healthcare with some concerns about some potential overcount in the number of health center patients who received PrEP, and the numbers published in the UDS are remarkably different from the CDC numbers for that same time period. There is a dashboard that shows prep in all the states, and I can send that out to see statewide numbers. But they just wanted us to call out that that you're reporting the count of those prescribed PrEP based on risk of HIV exposure and limited to FTC TDF or FTC TAF for PrEP. And the codes that were listed are not significant. So I can, there are some helpful resources on table 6A that are listed, and they go into more detail there, but just wanted to call that out. There's another example here that just a scenario that might help in thinking this through. So say a patient who has a countable visit gets a flu shot as part of a drop-in clinic that the health center is offering, and the shot is given by a nurse in understanding order, that would not be a visit on table 5. But the immunization, if documented in the patient's record, that would count in this table. So another scenario just to think about on regarding table 6A. Well, folks, that's, I think, a good stopping point for us today. I'm open to taking any questions. I'm going to submit, I haven't had a chance to submit, Mary, your question. I'm going to chat that into my chat line. And let me see if I chatted in also the question somebody said about BIPIC, understanding that many patients don't want to share household income. I got a response to that. Patients' income, from what our team has heard, patients' income helps you all as a health center better assess unmet need in the community. And to the extent that the health center is providing discounts to individuals and families with low income, providing my colleague Diane, she's going to be available for the flex time Q&A too. She said that oftentimes if you're looking for more guidance on how to collect that sort of or request that information, if the patients get sort of clarity on why you asked that, it sometimes helps obtain this information. But she's like, but we recognize this is hard. That was just her guidance, so I'm not sure.
Thank you. I mean, I think this is Mary. The reality is that when we're seeing an undocumented population, and just in general, a lot of patients are very paranoid about the government having any information on them. And so it's just extremely hard. I mean, we try and explain the benefits of reporting their income as it relates to being able to be on the slide and save money. And we also accept self-reported income. But it's just frustrating because when you look at the population that we're serving and the expectation that they're going to question the number of unknowns we have, it just seems to be a disconnect from my perspective about the population we truly are seeing.
Yeah. No,
we've had sanctuary patients, et cetera. And so, when people are afraid of ICE, they don't trust any governmental funded agency with their information.
Especially, I feel like last year, just that came to even more of there was so much tension there. So, yeah.
Thank you.
Yeah, I'm chatting in your other question about the advanced practice nurse and I'm putting it in my Q&A and see if they can give some clear guidance on that. Anybody else have other questions? I know people hate ending meetings early. So as I'm waiting for an answer to Mary's question, let me just remind folks about next week. So next week we'll come together and we'll start at table 6B. If you do have questions if they come up between now and then, Brandy, if folks can email you and you'll just send them my way, I can have those questions and get those answers to you just right at the start of the training. And we'll go through 6B through some tips for success. And then at the last 30 minutes, again, my colleague Diane will come for that last sort of Q&A, and you can bring any sort of challenging questions that you have, that's sort of the intent of that flex time, is to really go back and forth. Okay, well, and I'm not seeing a response. So instead of holding you here, Mary and others, why don't, when I get the answer, I'll send that back through Brandy. And I'll also, I don't know, Mary, if you're planning to be on the next training, but I'll have it ready for you for the next training.
Thank you. A quick question.
Yeah.
Do you guys have the opportunity to give feedback to a BIPIC about their instruction manual?
I can share it. I would be happy to share it.
Well, just on table 4, I think that they could probably make that explanation around workers' comp clearer.
Oh, yeah.
So that it's very clear that this is not where you capture really a subrogation.
Yeah.
And so the billing staff understand that, but the language to me was not specifically clear because the example was workers' comp.
Yeah.
And workers' comp doesn't usually get people thinking about homeowners or auto insurance or things like that, where you have medical liability. And so it just wasn't really clear what you report on 4 versus 9.
Versus 9. I guess the only, I think that feedback would be good for them to hear as far as the manual for folks that maybe don't have access to the training that. But I think that how I think about it is that that table is collecting patient characteristics about their insurance status. That table 9 is really that financial piece, and what was the revenue, what was the financial piece behind the costs, and how that was paid for. So is there a slide that articulates the prep information? So Laura, it wasn't in our slides, but I will send Brandy the actual language and the guidance on the prep piece so you can have it to refer to, and I'll send that back your way.
Thank you.
Yeah. All right. Well, thanks everybody for hanging in there. I know it's a lot of me talking. So I do, will there be, yes, 340B, absolutely. Oh man, we love 340B. So that will be covered next time. Clear as mud right now. So cool. All right. Well, I look forward to spending some time with y'all next week. And I hope you have a great rest of your day. And yes, I'll send the prep stuff to Brandy if Brandy's willing to just send it out, broadcast it to everybody.
Thank you.
Yeah. Okay. Thanks, everybody.
Thank you. Thank you, Megan.
Yeah. Talk to you later.